Good morning, everyone. I'm here to talk about the new WHO guidelines for prevention and treatment of PPH. But before that, I would like to thank the organizers for inviting me to be here, and also to the government of Bangladesh for hosting us. And I also would like to thank USAID not only for this meeting, but also for supporting the WHO work in guideline development in the area of maternal and perinatal health. And I'm trying to change the slides. Okay. And I want to start by remembering the definition of postpartum hemorrhage, which is any blood loss of more than half a liter within the first 24 hours after birth. It's considered as a postpartum hemorrhage. This is a common problem that affects 1 to 3% or more of women in developing countries. It's responsible for about 1/4 of maternal deaths globally, and it's the leading cause of maternal mortality in low-income countries. PPH is also not only this important cause of maternal death, but also an important contributor to severe maternal morbidity and long-term disabilities. And the most important thing about postpartum hemorrhage, on top of being this important cause of maternal mortality, is that maternal deaths due to postpartum hemorrhage are avoidable through essentially effective prevention and also treatment. When we talk about postpartum hemorrhage, we have to talk about uterine atony, which is the most common cause of PPH. But it's not only uterine atony that is responsible for postpartum hemorrhage. We also have genital tract trauma, uterine rupture, retained placental tissue, and also disorders on the maternal coagulation. These conditions, they are the main causes of postpartum hemorrhage. And there are some conditions that increase the risk of postpartum hemorrhage. Among them, we have, for instance, the grand multiparity or multiple gestations. But it's important to emphasize that in most cases, there is no identifiable risk factors associated with postpartum hemorrhage cases. And in the context of postpartum hemorrhage, we have to remember always that PPH is aggravated by pre-existing anemia, in the sense that the loss of a smaller amount of blood in anemic women may result in severe complications as well. In postpartum hemorrhage, and especially on the prevention of postpartum hemorrhage, there's an important period of time, that is the 3rd stage of labor, that spans the time between the birth of the baby and the placental delivery. And during this time, important actions can be taken to prevent the occurrence of postpartum hemorrhage. Particularly, what is known as the active management of 3rd stage of labor. That is a package of interventions that has been developed in the last 50 years and become the cornerstone of the prevention of PPH. When we look at the effectiveness of this package, we see that delivered as a package of intervention, the active management of 3rd stage of labor is associated with a reduction of over 60% of postpartum hemorrhage cases. This package of interventions, it consists initially of 4 components that along the time has been refined, but it initially was composed of 4 components. The use of a prophylactic uterotonic after delivery of the baby, early cord clamping and cutting, control cord traction of the umbilical cord, and the use of uterine atony. These are the classical components, and we will see how the evidence is shaping the use of these interventions in time. In the last year, WHO is working to update its recommendations on postpartum hemorrhage. Especially the two documents, the WHO recommendations for prevention of PPH that were issued in 2007 and the 2009 recommendations for treatment of PPH. In March 2012, WHO convened an international consultation to discuss new evidence and come up with updated recommendations. And this presentation that I'm delivering now, I'm going to present in summary the preliminary recommendations as they have been agreed by the panel. And the official release of these recommendations will take place during the summer 2012, possibly in August. I want to highlight the fact that the WHO guidelines, they are developed through a systematic process that includes the identification of critical topics, the extensive use of systematic review. For instance, in this guideline, we used over 30 systematic reviews. This systematic assessment of the quality of evidence through the grade process, the formulation of recommendations and perusal and discussion in an international consultation. And once the document is released, we have the work on the dissemination, implementation, impact evaluation, and also in the continuous update of these recommendations. In recent years, there is new evidence related with postpartum hemorrhage prevention. And this new evidence allowed an evaluation of the intrinsic contribution of each component of active management of third stage of labor. And overall, this new evidence may enable a simplification of the management of this period of labor. And as we are going to see in more details the evidence base of these recommendations, I'm going to focus in presenting to you the existing recommendations, and then the other panelists will go deeper in the evidence base and in more details relate to these recommendations. In the context of postpartum hemorrhage prevention, the key recommendation is that all women giving birth should use or should receive uterotonics during third stage of labor for the prevention of PPH. That's the key recommendation. And oxytocin is recommended as the uterotonic drug of choice. In settings where the use of oxytocin is not possible, the panel also recommends the use of other injectable uterotonics, for instance, the use of ergometrin and misoprostol, as recommended alternatives for postpartum hemorrhage prevention. In settings, as I said, oxytocin cannot be used. And when we think about those settings, especially where oxytocin is not available and skilled birth attendants are not present, the panel discussed the use of misoprostol at the community level. And there, we have now a clear recommendation, that is the use of misoprostol for the prevention of PPH by community health care workers and lay health workers is supported in settings where skilled birth attendants are not present. When we think about the use of community distribution directly to women, so the antenatal distribution of misoprostol for women's self-administration, the panel still regards this as a topic that merits further research and advises programs that are embarking in the distribution of misoprostol directly to women during the antenatal period to closely monitor the health outcomes related with this intervention. We also have looked at the postpartum hemorrhage prevention in the other components of the active management of third stage of labor, particularly the controlled cord traction, which was revisited due to new evidence. As we'll see in the next presentation, controlled cord traction is now regarded as optional in settings where skilled birth attendants are available. And it is contraindicated in settings where skilled birth attendants are not available. Early cord clamping is not recommended, and in the context of uterotonic use, uterine massage is not recommended for prevention of PPH. It adds very little in a setting where we are using the uterotonics. Cesarean section increasing globally, and we have now 2 recommendations specific to the prevention of PPH in C-section, where oxytocin is the recommended uterotonic drug for C-section, and the cord traction is the preferred mode of placental removal in preference to manual removal of placenta. Now I'm going to spend a few minutes talking about the treatment or the recommendations that are related to treatment of PPH. And when it comes to treatment of PPH, uterotonics play a central role in PPH treatment, and oxytocin alone is the first choice, the first option as uterotonic. We always remember or remind the importance of early fluid resuscitation, specifically with isotonic crystalloids, as an essential component for the management of shock and also for the prevention of organ dysfunction. And the importance of using uterine atony or uterine massage as soon as PPH is diagnosed. But in many or in some situations, bleeding will persist, and then in those conditions where we have refractory bleeding or persistent trauma-related bleeding, we highlight the possibility of using tranexamic acid. And there are some other interventions, such as the intrauterine balloon tamponade, that is recommended for persistent bleeding or if uterotonics are not available. There are few other temporizing measures, as you can see there, for instance, the bimanual uterine compression, the aortic compression, and use of non-pneumatic and shock garments that could be used as temporizing measures until substantive care is available. Important is that if bleeding persists despite treatment with uterotonic drugs, surgical interventions should be used without further delay. If the third stage of labor lasts more than 30 minutes, we have the situation of retained placenta, and in this case, controlled cord traction and oxytocin should be used to the management of this condition. And if there is no bleeding and the placenta is retained, another 30 minutes could be allowed to pass before implementing manual removal of the placenta. However, if the placenta is retained and there is bleeding, then manual removal should be expedited. And whenever implementing manual removal of placenta, it's recommended the use of a prophylactic antibiotic. The panel also did some recommendations related to the organization of care. And there are essentially 3 recommendations. The first one, that the use of formal protocols or development of plans and formalizing these plans at the institutional and health system level relate to the prevention and treatment of PPH, and as well for the patient referral is recommended. We also recommended the use of simulations for PPH treatment as part of training programs for improving the outcomes of PPH care. And the panel came up with a recommendation related to the monitoring of the quality of care related to the PPH management and prevention. So the use of uterotonics for the prevention of PPH should be then monitored, and a specific indicator was suggested, that is the proportion of women giving birth receiving uterotonics. To conclude, this is a summary of the recommendations that will be released by the WHO during the next couple of months. And we hope that these recommendations enable the implementation and development of health policies that are contributing to the improvement of quality of care and also then the reduction of maternal mortality and morbidity in developing countries. Thank you.